Well, to be useful, you need to have these tools where patient care is occurring. So in shoulder dystocia example, it's in the doctor's office with a medical record during labor and delivery. It is at the bedside. It is at the nursing station, wherever the clinicians are. Remember, one of the ideas that we're really trying to do here is to create a safety net. The clinicians are always there, but what happens if they get tired? We must expect that no matter how we legislate rules about how many hours people can work, they will, on occasion, be forgetful or be distracted. So to put that safety net where they're taking care of patients, to interact when they're taking care of patients.
And so you explain it can be in the doctor's office. Usually it is used during the labor, or it's during all the pregnancy.
Well, different applications are appropriate at different times. So, for example, we've also worked at looking at the baby's heart rate, which is recorded in labor, and we use very advanced algorithms to study that heart rate pattern and look for problematic areas. So that's happening while the mother is in labor.
Okay, and who can use these tools? Is it only doctors? Can it also be nurses? Who are the principal users?
Any healthcare professional taking care of patients. Anybody who knows how to do obstetrics can use these.
When did you start using those tools?
Well, we've developed a number. Some are 10 years old, and some are 2 or 3 years old, and some are brand new, 6 months old.
Okay, and since you have started using these tools, what are the results that you have obtained in terms of adverse events in obstetrics? Do you have an idea about that?
We have some ideas. We looked a long time ago at whether or not giving some people caring for patients in labor some assistance in evaluating how labor was progressing, whether or not that would reduce the rate of cesareans, and we were very pleased with those results. Shoulder dystocia with injury, because it is rare, takes some time, but we've been following now for 2 or 3 years, and we have found very encouraging results. We found that the rate of extra cesareans was less than what we would expect. And we found the rates of shoulder dystocia with complications appear to be diminishing.
Okay.
Our latest invention, which has to do with analysis of the fetal heart rate patterns, we're still evaluating what its impact will be. The medical record, in terms of reminding people not to give medications when people are allergic or prompting them that it's time to reassess a condition, that too has been followed by a number of parameters and very encouraging results regarding fewer babies with low APGAR scores, for example.
Okay. You said that a number of C-sections have been reduced during the year while using these tools. Is it because professionals were performing C-sections when they didn't have to use to, when they shouldn't do it, or?
I think it's quite comparable to any situation in where you have an intervention such as a cesarean is being performed given the best judgment of the clinician. Well, my judgment might be different from yours. My judgment today might be different from my judgment yesterday. But if you give clinician tools to measure things, to take away some of that subjectivity, then you will see a convergence of behaviors. And we've seen that with many kinds of devices in medicine. So by giving them a computer which could consistently analyze that progress, we saw a convergence of behaviors.
Okay. And so you're still developing new tools. What would be the next steps in your research activities?
Well, I could be here for a very long time, but I'll tell you one that's quite interesting. In labor and delivery, we often use a drug called oxytocin, which causes contractions to become more frequent and stronger. And unlike an antibiotic, it's not a single dosage regimen that everybody takes. You adjust it according to patients, and patients' responses will vary. And that drug is associated with too many contractions, and too many contractions can be stressful on the baby. So it's an ideal patient safety technique is to have a device which can keep track of the contractions and remind people when the contraction rate is excessive. So we are both providing this as a tool to clinicians and researching really what are the thresholds that are hazardous and should be alerted with high levels of concern versus minor, etc.
You just one of the tools that you have developed is using patient records to see if there are some allergics to remind clinicians of tasks that they have to do. Do you think it can be used in other departments than obstetrics? Are you
Absolutely.
thinking about maybe opening your tools to a wider, I would say?
To a wider? Yes and no. Part of the richness of this system is because there's a tremendous amount of what's called domain expertise, a tremendous amount of obstetrical knowledge in the people who have developed them. So it's not just a simple rule. So to develop rules which are really useful and not bothersome, it's easy to develop bothersome alerts. You need to have a lot of expertise behind the design of these rules. So there are some natural areas, women who have babies, for example, the babies, or the prenatal period. So there are some natural areas for extension. That's where we're concentrating on. But the concept that you could do this has been applied in other areas and absolutely could be widespread in medicine.
Dr. Hamilton, thank you very much.
Thank you very much, Pauline. It was a pleasure.